Good morning. I'm Shah. This is part of my disaster medicine elective. I have spent some time getting ready for this presentation. Things that I focused on today are the roles of hospitals in disaster scenarios, and then I will also be presenting my second presentation on disaster preparedness in the hurricane setting. So the objectives for this presentation today are to know the key elements of hospital disaster preparedness, understanding the frameworks and components of ICS and HEICS, which I will be going over later on in this presentation, appreciating the physician's roles during disasters and explaining different triaging methods, as well as recognizing special considerations for hospital preparedness. So all disasters follow a basic life cycle. In this PowerPoint presentation, I will be focusing on preparedness and response, but we can go over all of the elements of the life cycle. So the first part of the life cycle is prevention. So this is the outright avoidance of adverse impacts resulting from a disaster. So during this presentation, I will likely refer to several different types of disasters, but I will try to maintain examples mostly from hurricanes because that's what my second presentation is on as well. After prevention, there's mitigation. The point of mitigation is to lessen or limit the adverse impacts resulting from a disaster. Then there's preparedness. Preparedness is the knowledge and capacities developed to effectively anticipate, respond to, and recover from the impacts of hazardous events. This is the largest portion of most disaster life cycles. A lot of times you cannot prevent or mitigate a lot of dealing with natural disasters, but having that knowledge and capacity to be able to anticipate and respond to a disaster is the most important part of disaster medicine. Secondly, the most important part is response and recovery. Response is the provision of emergency services during or immediately after a disaster. And then recovery is the restoration or improvement of facilities and living conditions of disaster-affected communities. So an example of this would be, like I mentioned, if we're talking about hurricanes. Preventing hurricanes would be creating buildings that are sturdy enough to make sure that, well, prevention would be just making sure that hurricanes don't happen, which is very unlikely. However, mitigation would be making buildings proof for hurricanes and storm situations. Preparedness would be having a system in place for when hurricanes do happen. Response would be during or after the hurricane hits, what you're going to do about it. And recovery would be making sure that the community is able to bounce back after a hurricane hits and the disaster has been completed. So let's talk a little bit about impacts of disasters. In the last 20 years, natural disasters have killed over 3 million people worldwide. It has affected 80 million lives, whether it means that it displaces them from their living conditions, it affects their socioeconomic status, or any other reasons that it might have affected those lives. And it resulted in damages worth more than $23 billion. So what are some key elements of hospital disaster preparedness? So this is kind of what I was referring to earlier that we would go over. Key elements are understanding incident command systems, or ICS. This I'll talk about a little bit more detail, but it is basically the planning phase or the hierarchy of how to address a disaster or any situation where a task needs to be executed. The Emergency Operations Center would be the central location where most of the planning and tasks are executed. This might be like a central location in a hospital where all the information comes in and decisions are being made. Situation report or rapid needs assessment is that understanding of the situation and collecting the data that is needed to make the decisions for this disaster. So a good example of this would be if a hurricane was to hit a hospital. There would be an incident commander who would be the main person who makes all the decisions for the hospital, and we will talk about those decisions that need to be made a little bit later. But then they would have an emergency operations center where all of the key personnel would be located and all the information goes to about supplies, the weather situation, the patient's needs, and how to execute all of that information. Then the situation report would be the information that comes into those that group of people, which would include like I mentioned, the supplies that are needed and the supplies that are provided, and the patient's needs. Another element of disaster hospital preparedness would be triage system. So especially in disaster situations, there needs to be a way to triage patients based on needs and assessments. Communications is a key part of all of this as well, because often in disaster situations, the normal modes of communication have been disconnected or unavailable, such as cell phones or overhead communication. A lot of times during hurricane situations, hospitals will lose electricity, so making sure that there's a good way to communicate with all the parties involved in a disaster is essential. Of course, the disaster supplies is very important as well. This includes the blood or the water, anything that a patient needs, basically the available resources that are used for patient care. Then physical security. This is multifaceted, but basically is ensuring the security of the patients and the volunteers that are providers as well. And then PPE and scene safety. So as we know from COVID this year, PPE is essential. This includes just protective equipment, whether that be masks or gowns, but also scene safety. It is essential to make sure that when a provider is taking care of a patient, they don't harm themselves and in turn become a patient as well. So assessing scene safety and making sure that it is safe to actually provide the care that they are providing is essential as well. So this is the basic algorithm for an incident command system. This is the hierarchy that I explained earlier of basically who makes decisions and what decisions that are being made. So on the very top of everything is the incident commander. This is the main person that will make most of the decisions or delegate decisions to be made by other people. All information, of course, cannot go to the incident commander, so information will start from the bottom and be addressed by their direct supervisor until the important things will go to the incident commander. Same way, once an incident commander makes a decision, it will go down to each level of the hierarchy and decisions might be made or delegated likewise. So we will talk about the different parts of this incident command system, but the main portions of the incident command system is the incident commander, the public information officer, the liaison officer, the safety officer, the planning committee, the logistics committee, the finance committee, and the operations committee. Often when we think of disaster preparedness and response, we think of the operations committee. That has to do with the people that are actually on the ground doing the actual work that is involved in taking care of the patients and people affected by the disaster. However, one thing to understand is that there's a large amount of planning that goes into each thing that happens in each disaster situation. Each decision in itself has to go through the correct channels, and also have been very meticulously planned. So let's talk about the command staff. These are the people that are directly under the incident commander, and they have very specific roles. One of the most important roles is the safety officer. This person ensures the safety of all assigned personnel. So this includes all of the providers, all the volunteers, all the people that are involved in this actual execution. So then there's the public information officer. This officer manages information to and from external and internal stakeholders, such as media. This is especially important during disasters because media plays a huge role in the outcome of a disaster. For example, during Hurricane Katrina, there was huge media coverage throughout the entire process. This is also how you are able to get the word out about a disaster's actual effect, and also get volunteers to come help. The last part of the command staff is the liaison officer. The liaison officer is the primary contact for supporting agencies assisting this incident. This would be, for example, if a hospital during a disaster has a liaisons officer, they are under the incident commander on how to take care of, address the disaster directly, but also working with a supporting agency such as other hospitals or on a larger scale, possibly like FEMA. So the liaison officer would be the main person that would address the communication between these supporting agencies and the incident commander. The general staff. So there are four main categories for general staff. There is the planning staff. They are tasked with the overall accountability of incident, including scene information and tracking of resources. For example, in a hurricane situation, if there has been extensive flooding, then making sure that the entire scene is assessed and understanding how much damage that the flooding has caused would be part of the planning staff. In addition to that, tracking the resources, so in fuel, an example that I mentioned prior with flooding of hurricanes, making sure there's enough fuel to manage the generators would be essential. So tracking the resources of fuel would be part of the planning as well. Logistics would be have to do with tasks with providing all resources, services, and support required for an incident. So in a hurricane situation, there are several operations that usually are going to occur, but one example would be patient care. The logistics team would make sure that all the resources, services, and support is provided. This includes making sure that there is appropriate fuel for the generator, but also, so there's electricity for the providers and the patients. There is labs that can be done. There are treatment methods. So once a lab or imaging has been done to diagnose a patient, making sure that there is ways to treat these actual patients as well. And so these are all things that logistics staff would take care of. In addition to that, there's the finance, who are tasked with tracking compensation claims and resource costs. So this is sometimes overlooked in disaster situations because cost is not considered important over patient care. And however, it is very important because often these disasters can be detrimental to a hospital's overall income, but also a community as well. So making sure we take care or record compensation claims and resource costs can be an important and essential part of the entire planning of an operation. And then finally, the main thing that we talked about is the operations staff. These are they are tasked with directing all actions to meet the incident, and generally they're the largest portion of the incident's response. This would be an example of this would be, like I mentioned prior, the providers that are taking care of patients, but in addition to that, the nursing staff and everybody else that is involved in the actual operations. So how does this incidents command system actually affect a hospital, or how does it look in a hospital setting? This incident command system actually is used in several different operations, including the military, in disasters, and it's really a benchmark of how to address large-scale incidents. So when you apply this concept to a hospital, it can look very different, and it's sometimes a little bit hard to see how all the parts of a functioning hospital and try to figure out how to make all of them work together to make sure that everything flows very naturally. So that's when the hospital emergency ICS comes in, and that's, like I mentioned earlier, the HEICS. So it follows a very similar pattern to what I described earlier. It still has the incident coordinator or the incident commander, and underneath it, it has the public information officer, the medical officer, safety officer, and then it still has the logistics, planning, financing, and operations heads. But the nice thing is that this diagram nicely demonstrates what goes under each of these planning heads, or these possible heads. So the logistics head, it obviously has the data assessment and control officer, but it also has things like a sanitation systems officer, a communications unit head, a transportation units head, a material supplies unit, and feeding system unit head. So one thing that we don't think about is if there is a disaster that hits a hospital, how do people communicate with one another? It could be overhead, it could be via cell phones if that's still an option, it could be pagers, all those things. But there has to be one person that's responsible for communication and making sure that all communication is effective and thorough. In addition to that, there's transportation unit head. So patients need to be transported from one place to another. This becomes incredibly important in hurricane situations where patients need to be evacuated, which I will talk about later during my next presentation. However, that is a huge consideration that you need to make sure that you don't overlook. And then there's the material supplies and the feeding supplies. This can include like things involving patient care, but in addition to just patient care, it could also be the food and water that is needed to sustain the providers and the nursing staff and the patients and the volunteers, which could be a huge undertaking in itself alone. So then there's the planning head. This usually includes the situation state unit head, the task forces unit head, the medical staff unit head, and the nursing staff unit head. So this is not the most thorough of diagrams, but it does a really good job of kind of giving an example of how to work through all of these places and where these different heads will actually go under. So things that you want to remember for a nursing unit head is that you want to follow up with patients. So there needs to be a patient follow-up officer and reporting on patients officer as well. So those are some considerations that you need to make as well in the planning stage. The financing head, the biggest parts are funds for supplies and collections unit, and the claims unit, and the costs unit. Like I mentioned, this can be sometimes overlooked, but it is essential nonetheless. Finally, the operations head. This can be extremely intricate because there are so many different operations that are running simultaneously in a hospital. The most common is the medical director head. This has to do with direct patient care. This can be the providers, volunteers, and nursing staff, which each department would have their own head. For example, inpatient areas, there's a supervisor that heads the surgery unit, the mother-child care unit, the intensive care unit, the general nursing, and then also there's an outpatient care. The treatment sector supervisor would make sure that there's They are responsible for patient priority classification, delayed treatment units, minor lesion treatments, hospital discharge units, and a very important part of it is the morgue. Especially during disaster situations, there can be a huge death toll, so the morgue is something that needs to be considered during these situations as well. I will talk a little bit more about that later during this presentation as well. Then there is the human services and the Axillary Services. So this involves the laboratory, the imaging, the pharmacy, and also just making sure that you provide services for the human services. So this would be like if a nursing staff comes in to volunteer during a disaster situation, you have to make sure that if they have children, someone is taking care of their children, or how do you feed that nursing volunteer? How do you ensure their own safety, things like that. A huge part of this is also providing psychological support for all the volunteers, providers, nursing staff, and the patients as well. So all of those can be listed under the operations as well. So the biggest question for this presentation that I wanted to address was, what is a physician's role during disasters? How can we help? A big part of it is involving patient care, but the AMA listed physicians' responsibilities in disaster response and preparedness. And they put out an official documentation that outlines their responsibilities in these disaster situations. So the AMA lists 3 major things that physicians are responsible for. The first one being take appropriate advanced measures, including inquiring and maintaining appropriate knowledge and skills to ensure they are able to provide medical services when needed. The second one is to provide medical expertise and work with others to develop public health policies that are designed to improve the effectiveness and availability of medical services during a disaster, are based on sound science, and are based on respect for patients. And then the last thing that they are responsible for is advocate for and participate in ethically sound research to inform policy decisions. So this has a lot to do with disaster preparedness, and physicians definitely play a role in all of this. But for us as physicians sitting here, if we think about our role in a disaster situation, for example, if a hurricane hits Cape Fear Valley Hospital, what do we do? Who do we respond to? Things like that. Those are all questions that seem a little bit unanswered for us. So the biggest thing that I can say is that the most helpful role that we will probably play in a disaster operation is triaging. So there are 3 forms of triaging. There's on-site triaging, there's medical triaging, and evacuation triaging. Of course, the main thing that we think about is actual medical care, but who gets what medical care is the first step in providing that medical care as well. So that's something, and that's also something that physicians don't get a lot of training in, so I thought I would talk a little bit about that as well. So on-site triaging. Unless the physician is actually on site where a disaster happens, they likely will not be doing this kind of triaging. However, this is usually done by EMS, paramedics, things like that, and they're the ones that determine the first where a patient goes or how they are treated. So they are color-coded red, yellow, green, and black by tag, tape, or marker. So in a disaster situation, you just need to find some way of identifying a patient. Like I mentioned, it could be tags, it could be tape, colored tape, it could be colored markers, some way of quickly assessing a patient and making sure that they are tagged so that someone else can assess or knows the assessment is done and where they should go. Often on the on-site triaging, you want to consider grouping reds and yellows together. The reason this is important is because reds and yellows often are transported to the hospital. Greens are usually people tagged as green are usually people that are able to take care of themselves or are don't need immediate medical care. So they often do not go to the hospital. It is important to tag or group yellow and red together because often a presenting symptom or presentation might not be indicative of how severe the disease or injury might be later on. So if you think that someone is a red or a yellow, they need to all be going to the hospital for further medical triaging. So once they reach the hospital, then you do the medical triaging. The medical triaging is divided in a similar fashion, but what each color stands for is a little bit different. So reds, they require immediate stabilization. So this could be people that need to be intubated. Can be people that need immediate care, traumas, ICU patients, things like that. Yellow is people that have delayed treatment with close monitoring. So these are people that might not be crashing currently, but they are at risk of crashing fairly soon, so they need to be monitored closely. And then green are people that can wait or do not need treatment. Often people that come into the hospital as yellow or red, on-site triaging will not be green, but sometimes after a little bit of monitoring, you can notice that they might not need as close of monitoring or treatment as some of the other patients that make it to the hospital as well. And then the black, unfortunately, is marked for people that are deceased. These are people that need to be quickly transported to the morgue so that other patients can replace them that might be yellow, green, or red in color or in categorization. And then there's the evacuation triage. So this is important for evacuation settings, which is often a huge consideration for people that are in hurricane situations in hospitals, for example. So this is a similarly tagged or divided, but red in this case means highest priority for need of tertiary hospital. So these are people that need an ICU that's functioning or they need immediate surgery. So these are the people that need to be transported or evacuated immediately as soon as possible. Now, keep in mind that this might not be as quick as we are used to, but nonetheless, they are the highest priority of people that need to be transported. Yellow is the next set of people. They are the people that are currently stable, but they may decompensate. After all the people tagged as red have been transported, they are the next people to be considered for transportation. And then green are the people that are discharged on site. So in an evacuation setting, that might be people that are capable of going home if a disaster is on its way to being almost done, or they might be people that can evacuate themselves, people that can drive to a different location, or have people that can drive for them to a different location and are stable enough to actually drive to that new location. And then black is the people that need to be transported to the morgue. So here's two algorithms that are used for adult and pediatric triaging. The START method is for adult triaging, and the Jumpstart is usually for pediatric patients. So this is usually comes into play for the medical triage, like we mentioned earlier, and this provides a really good way to assess patients quickly and determine their needs as quickly as possible. So, is a patient able to walk? When you walk up to a patient and you go to start assessing them, are they able to walk? If they are able to walk, then in a disaster situation, they are considered minor and they will go directly to secondary triage. If they are not able to walk, are they having spontaneous breathing? If they are not having spontaneous breathing, they need to position the airway, and if it's if they do get spontaneous breathing, they are considered immediate, and if they are apneic, then they are expectant. Expectant is the equivalent of a black triage tag color. So they are. This can be people that are already dead or very unlikely to survive given the severity of injuries, level of available care, or both. Usually for these patients that are still alive but very unlikely to survive, palliative care or pain relief should be provided. Let's say that the patient is able to spontaneously breathe. How are their respiratory rates, or their respiratory rate? If it is greater than 30, then they are considered immediate, and they should be the red triage tag color. If it is less than 30, then you move on to perfusion. If they have absent radial pulses or capillary refill of greater than 2 seconds, then they are again immediate. And if their radial pulse is present or their capillary refill is less than 2 seconds, then you check their mental status. If their mental status says that they cannot obey commands, they go back to the immediate section, and if they are able to obey commands, then they are delayed. So, like we mentioned, immediate means that is a red triage tag color. This is victims that can be helped immediately by intervention or transportation. They require medical attention within minutes to survive, up to 60 minutes, and includes compromises to patient airway, breathing, and circulation, which is basically what we went over with the spontaneous breathing, respiratory rate, and perfusion. The delayed care are people that have the yellow tag. These are victims whose transport can be delayed. It can include serious and potential life-threatening injuries, but the status is not expected to deteriorate significantly over several hours. So an example of this would be broken bones or injuries such as that they, unless it is something that needs attention immediately, often very simple extremity broken bones can be delayed for care as long as their pain is managed pretty thoroughly in the meantime. And then minor is the equivalent of a green triage tag. That is where a victim has a relatively minor injury. The status is unlikely to deteriorate, and they may be able to assist with their own care, which is often referred to as the walking wounded. So this might be people that are like shooken up from a disaster or things like that, but overall are relatively stable. For children, we use the Jumpstart Method. The Jumpstart Method is very similar to the START method. It just has slight differences. So again, it starts with the question, is the patient able to walk? If the answer is yes, then they are considered minor and they are going to secondary triage. Evaluate infants first in secondary triage using the entire Jumpstart algorithm because infants are usually a priority in these situations. So then after we have assessed all of the minor or determined the patient is minor, if they are not able to walk, are they breathing? If the answer is no, then we position upper airway. If they start breathing after positioning the upper airway, then they are considered immediate. If they are apneic, then you check their palpable pulses. If they do not have palpable pulses and they are apneic, then they are considered deceased. If they have palpable pulses despite being apneic, then you administer 5 rescue breaths. And if they remain apneic, then they are considered deceased. And if they are breathing after 5 rescue breaths, they are considered immediate. Then if they are breathing, you go down to respiratory rate. So the respiratory rate is a little bit different. Like the START method, we use 30 as the magic number for respiratory rate. Here, it's going to be less than 15 or greater than 45. So if a child has a respiratory rate of less than 15 or greater than 45, they are considered immediate. And if it is anywhere between 15 to 45, then you move on to check the palpable pulses. And for palpable pulses, if they don't have palpable pulses, they're considered immediate. And if they do have palpable pulses, then you do AVPU assessment. So AVPU is A stands for alert, V responsive to voice, P responsive to pain, or U unresponsive. So if they are inappropriately responding to pain, posturing, or unresponsive, they would be considered immediate care. If they are alert, responsive to voice, or appropriately responsive to pain, then they would be considered a delayed. So this is a good algorithm to use for triaging patients. It's obviously, it's not something in a disaster setting you're going to pull up, but as long as you have been through the algorithm once, hopefully you can remember the basic portions of it. They all center basically airway, breathing, and circulation for both adults and pediatric patients. Things that you want to be prepared to do in disaster situations. You want to be prepared to do initial triaging. In addition to that, you want to allocate diagnostic and therapeutic resources. So it's the physician's responsibility to determine whether their patient has a need for diagnostic or therapeutic resources, and categorizing them when diagnostic and therapeutic resources are limited. For example, if you are taking care of like 5 patients and you determine that one of the patients needs blood, this is information you would actually use the incident command system to go up the ladder and say that you need 1 patient of your 5 that needs blood. The reason this is important is when a physician's taking care of their patients, their 5 patients are the most important patients to that physician. So regardless of everything else that's going on, if your 1 patient needs blood, you're going to do everything in your possibility to get that patient blood. However, if there are only like 5 bags of blood in the entire hospital, it is not your responsibility to actually determine if your patient is the most in need for that bag of blood, or if it will be saved for other patients from other physicians' care. So that is something that's kind of an example of how the incident command system is used in disaster situations. You are also be prepared to provide active medical care. This is the thing that we're probably most used to and the thing that we feel most comfortable doing in a disaster situation. However, the other things that we want to be able to do is determine evacuation triage categories. You will probably treat populations unfamiliar to you. So while we are used to the bread and butter things that we are used to seeing in the hospital, often disaster situations will cause victims that we're unfamiliar with those diseases or injuries. This could be like respiratory problems due to smoke in the air, burns from wildfires, flooding, drowning victims, things that we're not typically used to taking care of. So be prepared to take care of those populations. And something that goes along with that is treating unusual conditions. Like I mentioned, they're things that we don't typically see. So some ethical and legal considerations for disaster preparedness. You want to realize and recognize that you must shift to providing care and allocating scarce equipment. So the idea is to save the largest number of lives, which is population-based, versus the traditional focus on saving lives, which is individual-basis. Often in our care, we focus on individual-based care, so that means we have unlimited resources and we provide the resources that is best needed for each individual that we care for. However, in a disaster situation, you have to understand that there are scarce resources, so some patients will not get the care that they need. That doesn't mean that they're not worthy of it, but we are trying to save the largest number of lives, so that is how we have to shift our focus during a disaster situation. You still want to adhere to HIPAA and EMTALA requirements. Just a quick summary, HIPAA is privacy, so that is a little bit more difficult in disaster situations. You might not have an individualized room for each patient, but as much as possible, you do want to maintain a patient's privacy. And then EMTALA requirements involves taking care of a patient regardless of insurance or financial status. And that's a little bit easier in disaster situations in the sense that you don't really know if what the social economic status of a patient is when they come in. A victim that needs immediate care can be triaged and treated appropriately regardless of financial status. You want to also be cognizant of arrival of solicited and unsolicited volunteers, which necessitates a plan for credentialing, privileging, utilization, and supervision. So you're going to have, if something happens at Cape Fear Valley, you're going to have the providers all come in. You're going to have the emergency medicine doctors, the surgeons, the ICU providers. You're going to have the family medicine doctors, but you're also going to have pediatricians and IM specialists like nephrologists, cardiologists, things like that. You need to make sure that they are utilized to their best abilities. If that means, often the emergency medicine, ICU, and surgeons are going to be the ones that are focusing most on patient care, then the other populations of physicians can do triaging. But you want to make sure that they are credentialed and they're utilized in ways that they can be useful. In addition to that, you're going to get unsolicited volunteers often. You might have people that were not harmed directly from the disaster that need to be, that want to help with patient care. Same as a hospital, you can't have just anyone take care of patients, but you can have them help with other things like transportation of patients, things like that. Use your resources the way that they are provided to you. You also want to maintain some supervision. So using that incident command system that we talked about earlier, making a head of those volunteers is really important to make sure that they have someone to report to and they're part of the system just like every other part of the system in this incident. And then investigative medication procedures may need to be revised or abandoned. So things like checking x-rays or checking for broken bones and things like that. If that's not a possibility, if you don't have electricity, then you really just have to work with what you have. And sometimes trying to get an x-ray to work might be futile, and it might just need to be abandoned. Maybe you just need to treat patients based on what you can see instead of using the x-ray machine. So just being able to reevaluate everything that you normally use to take care of patients and being cognizant of that is really important. Some special considerations for hospital preparedness. This is kind of a section for all the extra stuff that you want to consider when taking care of hospital preparedness that might not fit in other places. So distribution of casualties, ensuring one resource is not overwhelmed while nearby facilities and resources remain unused. That means that often patients are taken to the closest hospital. That hospital might be overrun with patients and have decrease in resources because they were the closest to the disaster as well. But a few miles away, there might be a different hospital that's not being used at all. One thing to keep in mind that we have Cape Fear Valley here, but we also have Womack in the town. People don't always think about that. So making sure that the victims are taken both here and there, hopefully by availability of resources and things like that. So making sure you don't pigeonhole your thought process and only consider one resource is really important. Communications. I've kind of mentioned this earlier, but communication is vital to making sure that everything runs accordingly. So you want built-in redundancies. There can be a lot of miscommunication through this entire process and all the chaos, so you want to make sure that there's closed-loop communication and built-in redundancies over and over and over again, just to make sure that nothing falls through the cracks. You want to avoid acronyms and specialized jargon. In this situation, you're often going to be working with people that are not used to your typical specialized jargon. If a physician is working with a different physician, they might know what you're talking about, but often you might be working with someone that is helping you out that is a civilian, that has no medical knowledge. If you ask them to do something and use specialized jargon or an acronym, that's going to provide or cause some miscommunication with you and the person helping you. And then Common methods in disaster settings include communications on wheels, which is considered cows, radios, or as a last resort, message runners. Radios are typically the most effective methods of communication in disaster situations because they require limited amounts of electricity and they can span large distances as well. But if all else fails, at the end of the day, you might just have to designate someone to run messages from one place to another. And if that is the case, then make sure you plan that into your incident command system and have someone that is responsible for all of those runners and make sure that they get where they need and things like that. So at the end, message runners is a possibility for a method of communication as well. Admission, identifications, and tracking. So backup tracking systems should be in place and be able to manage unidentified patients. When you have a large disaster that occurs, you're going to often have unidentified patients that come in and you need some form of admission, identification, and tracking. So our EHR probably would not be working in any major disaster situation. So you need to make sure that there are paper charts or there's markings on the patient or whatever it may be. You need to make sure that there is some backup tracking system to make sure that patients are identified as treated, not treated, where they are in the process, things like that. Other considerations, mass fatalities. So morgue space, like I mentioned earlier, can often be limited in most hospitals, especially during disaster situations. Alternatives sometimes include refrigerated storage trucks and ice rinks. Really, you use whatever resources you have available to you. So in mass casualties, you might need to utilize these other resources that are unconventional to normal methods, but you do what you have to do. Disaster pharmaceuticals. There needs to be readily available pharmaceuticals to avoid essential loss, life-saving time, while personnel obtain critical medications. So basically what this means is that often strong medications are locked away and difficult to get a hold of, which is by design most of the time. However, if you are waiting for that medication and you absolutely need to have it, the pharmacist needs to make sure that those medications are out of those containers and readily available for the patients that need it immediately. Blood, antibiotics, and vaccines need to be stockpiled and kept in appropriate storage. So a lot of times, like vaccines, for example, they need refrigeration. So just being aware of that and making sure you understand that if refrigeration methods are gone, how else are you going to store these vaccines? It might even be, like we mentioned, you have to reassess the need for some of these resources. Maybe storing a vaccine is not a priority in a disaster situation, and you really want to prioritize blood and antibiotics, so you let some vaccines go. But keeping in mind that a lot of times these disaster situations can have long-term effects. So vaccines can be important in even disaster situations. So just keeping that in mind is really important. And then ancillary services. So a hospital it functions as a hospital where it provides direct patient care. However, it often does function as restaurants, laundromats, and lodging. People will seek shelter there that would not typically come to a hospital. They also provide water, sanitation, and hygiene services for a large number of people. So you want to just keep in mind that that is something that will happen and something that you need to account for. And then disaster mental health services should be provided for both the responders and the victims. So that is something that I mentioned earlier as well, but it really needs to be considered as well. So these are my resources. This was kind of a summary of basic hospital preparedness in most disaster situations. I hope that this was helpful in kind of giving you a starting point of where to start if there was any disaster that were to occur in your hospital. And hopefully you find that helpful. Thank you. Have a great day. Again, just a quick introduction. I'm Shafali. I'm doing my disaster medicine elective this month, and I have focused on a lot of interesting things, but the focus of this PowerPoint is going to be disaster preparedness, specifically in hurricane situations. There was obviously a lot of information based on this topic, but I thought that the focus of it is really just how to, I'll talk about it in the objectives. So objectives of this PowerPoint presentation is I'm hoping that we can acknowledge the impact of hurricanes on society and healthcare. We can identify health effects affected by hurricanes. We can name common illnesses and injuries treated as a consequence of hurricanes, and understand common pitfalls in hospital preparedness, appreciate the complexity of the decision of evacuation versus shelter in place, and recognize hospital evacuation decision tools. So a lot of this kind of overlaps my last presentation on incident command systems. For the focus of this PowerPoint presentation, I'm not going to really talk about incident command systems and things like that, but more so just things that are unique to hurricane disasters. Let's talk a little bit about the major hurricane that everyone thinks about when thinking about hurricane disasters, Hurricane Katrina. So Hurricane Katrina displaced over 1 million people and destroyed over 350,000 houses. The death toll of Hurricane Katrina was about 1,300 people, and the economic impact was over $100 billion. Originally, people were fairly well prepared for hurricane disasters in New Orleans. They thought that they were taking care of addressing Hurricane Katrina fairly well. They had several resources, such as water and food, and they had fuel for their generator, things like that. However, hospital preparedness only planned for about 4 to 5 days of supplies, and then having the levee breach caused some devastating flooding. And to make things worse, most of the food, water, supplies, and fuel were all stored in basements. So when the levees breached, all the flooding completely destroyed all the supplies that were stored in the basement, and that became more or less unusable. Evacuation methods were unavailable or too slow to the degree that was needed at that time. So, even once we realized that we were not able, or they were unable to take care of people in the hospital, trying to evacuate patients was just not really feasible, and that's why Hurricane Katrina was considered such a devastating actual disaster. So hurricane health effects. Let's talk a little bit about what hurricanes physically do to environments and patients. The biggest effects of hurricanes are wind forces and flooding. They do several different things, but the main thing that everyone thinks about is infrastructure damage. So it gets rid of transportation, electricity, housing, and healthcare opportunities. It also gets rid of or causes pollutants and contamination, which I will talk about later on as well. But the main things, it contaminates the water, it pollutes the air, it has bioaerosols and persistent pollutants. It also has changes in socioeconomic and socio-physical and biochemical environments. These are all kind of intertwined, but the big thing is that it gets rid of access to healthcare, which causes socio-physical environmental stress on an individual and a society perspective, and that'll help affect health effects of morbidity, mortality, and pregnancy outcomes for populations. So the big thing that I want us to understand about hurricane health effects is really that it doesn't just affect one source of aspect or one aspect of healthcare. It affects several different aspects of healthcare, so it can be a very complicated disaster and very difficult to treat as a result. So a little bit about morbidity and mortality effects. The common short-term effects of hurricanes are injuries, drowning, heat stress, infectious outbreak, and health impacts, which include exposure to toxins, population susceptibility, and healthcare system infrastructures. So on this table here, it right next to the text, it kind of talks about the diseases that were impacted due to the hurricane, and then the time lag that was associated with those things. So kind of like what we talked about in the 1 to 3 months to even up to 6 months, things like injuries are very important, but also you can have cardiovascular effects, respiratory effects, and infectious effects as well. And then when you go to long-term effects, you're looking more at socioeconomic burdens, worsening comorbidities, morbidities and mortalities related to mental health impacts, and something called the Katrina Cough. So, examples of these things, people whose houses are destroyed, they can have huge socioeconomic burdens. They experience homelessness. The securities that are provided by a household are no longer available to those individuals and those victims. They can have worsening comorbidities. So if you already have diabetes or you already have cardiovascular problems, you no longer have access to the insulin that you need, the medications that you need, those things. So once you have a comorbidity, obviously it is at high risk of worsening due to the lack of resources that are available to you. In addition to that, mental health is a huge concern. The mental health, as shown on this table here, shows that it was really a long-term effect more than anything else. It really affected patients about 12 to 36 months out of the disaster. This can include worsening depression, but also PTSD, things like that. For victims and healthcare providers alike, it can be a huge mental health impact. And then the last thing is the Katrina Cough. So this is something that was recorded after Hurricane Katrina because it was an effect of respiratory health secondary to the pollutants that were in the air after the hurricane, which I will actually talk about a little bit more later on, actually right now. So the chemical effects of hurricanes. There are a few big ones that we don't typically think of, but it's really important to actually think about. So hydrogen sulfide, it is actually a common runoff of agricultural land, and as a result of flooding, it can become airborne and cause several respiratory illnesses as well. There can be increased concentrations of chemicals such as aldrin, arsenic, and lead. 37% of soil samples exceeded screening guidelines for arsenic concentrations post-Katrina. So all of these substances that are typically not recommended or are very dangerous for patients and are usually at a pretty low level due to screening guidelines, they can take a huge jump in the soil due to the flood as an effect of the flooding. There can be an increase in bioaerosols such as mold and endotoxins that can cause respiratory illnesses such as sinusitis, toxic pneumonitis, and the Katrina cough, which is what I previously mentioned. It can be present up to 2 months after flooding, so it is considered more of a long-term effect of hurricanes. So if you are in a location where a hurricane is hit and you see patients that have these symptoms, definitely consider these as potential causes for the symptoms that you're going to be seeing. And then exposure to airborne chemicals due to loss of electricity. The biggest one is CO2 poisoning. After Hurricane Sandy, there was an increase of 283-fold in gasoline exposures compared to prior. This is because the flooding often got rid of the fuel and aerosolized it to cause more airborne chemicals as a result. So these are all things that we typically don't think of as effects of hurricanes. Typically we think of like flooding and drowning as the main things, but these are also very important things to consider. In addition to that, the flooding can really affect hygiene and sanitation services. So illnesses are widespread and just run rampant in hurricane settings. The thing about hurricanes is it can often cause an immediate casualty effect, but often more than that, it causes long-term effects that really can affect the community in ways that were not originally anticipated. So just keeping that in mind is very important. Factors that modify health effects. Obviously there's the environmental stressors, but there's disruption in healthcare delivery. I kind of mentioned this a little bit earlier too, but there's interruption of healthcare delivery, there's inadequate access to healthcare, so whether they can get transportation to healthcare or not, there's a lack of access for pre-existing conditions such as the insulin and diabetes, there's inequalities of accessing care, so there are limited resources, so being able to access all of those resources for everybody sometimes can be very difficult, and the medical equipment limitations as well. Like I mentioned, there might not be enough equipment or resources available to a large population. So modifying risk factors that exacerbate health risks. These are age, pre-existing conditions, and socioeconomic status. None of this is really new information to us, but it is something that is important to keep in mind when addressing health of populations affected by hurricanes. So common pitfalls that are associated with hurricanes. The big things are a lot of our healthcare is reliant on electricity. And so electricity is a huge part of making sure that a hospital is functioning. Generators are really good. They are often created, backup generators are in place to make sure that there's no interruption of care during a disaster setting, specifically like hurricanes. However, generators are often stored in basements. Sometimes they're encased in concrete to prevent flooding up to about 12 feet. But as seen in Hurricane Sandy, the floods came up to 14 feet, causing generator failure. So just making sure you are aware that sometimes even the things that we plan for might not be enough. That is important to kind of keep in mind. Their food, water, and supplies were often stored in basements as well, like I mentioned. So once the flooding kind of hit all the buildings, all of those resources that we had originally prepared for as really good measures to make sure that we were prepared for the hurricane, they became obsolete and almost a detriment to us. Joint Commissions recommends hospital function independently for 96 hours. So especially in settings where hurricanes or a hospital is at high risk of being hit by a hurricane, they need to be able to make sure they can function for up to 96 hours independently with no outside help. This can be a very real reality for a lot of hospitals where evacuation methods and outside help is not able to help someone for several days sometimes. And then they also recommend monthly assessments for safety, but this is often overlooked by hospitals due to interruption of patient care. It's really hard to get everyone on board to participate in a monthly assessment for safety and make sure that they are prepared for a hurricane when the likelihood of a hurricane actually devastating a hospital might seem inconsequential at the time. But it is really important that even though it seems like it's not something that is immediately important where patient care might seem more relevant at that moment, that we are preparing for it, because hospital preparedness is super important when a disaster actually hits, and that could be just life-changing for so many people. In addition to that, there's no consistent criteria to guide evacuation decisions. During Hurricane Sandy, I'll talk about this a little bit later, but there were several hospitals that had similar resources and similar situations that made different decisions based on in-place stay or evacuation, pre-evacuation or post-event evacuation. And there wasn't really a rhyme or reason for why each one made the decision that they did. So I'll talk a little bit about one study that explains what went into the decision-making factors of evacuation versus in-place stay a little bit later. The big thing that you want to worry about in a hospital setting during hurricanes is evacuation. And this is something that maybe as physicians we might not be directly responsible for. This might be an incident commander decision. However, it is something that we should be very aware of, and we will be a part of if the decision is made that we want to evacuate a hospital. Evacuating a hospital is a huge undertaking. The decision is very complex. Evacuating prematurely puts patients at risk, and waiting too long can also result in devastating consequences. There are a lot of considerations that have to be in place to determine whether evacuation is safe. The power for life support equipment, patients in the ICU are on ventilators and all these machines. Making sure that they stay on these machines as they are evacuated can be really difficult. In addition to that, how do we move patients safely without functioning elevators is a huge hurdle that a lot of people have to overcome. Hospitals are so many floors high, and getting patients that are bedbound down several flights of stairs can be really time consuming and use a lot of resources. And then there are infrastructure vulnerabilities as well. So this includes the generator flooding, like building collapses, things like that. Just things that you really want to worry about when considering the decision to evacuate a hospital. Then there's also pre or post-event evacuations. They differ greatly. So like we mentioned before, pre-event evacuation might be safer for the patients and give you more resources for the evacuation. But if the disaster does not hit as greatly as expected, that could be really dangerous. It could also be career ending for whoever decides to evacuate the hospital prior to an event. So that is a huge consideration. In addition to that, post-event evacuation is significantly harder in the sense that the resources are so much more scarce. So, like I mentioned before, we have to worry about the life support equipment, actually transporting the patient, things like that. And those are all considerations more so for post-event evacuations. And then there are limited tools to make decisions to evacuate. Like I mentioned before, there's no real consistency, or even if there is, they aren't being used currently. So based on one study that was done during Hurricane Sandy, it explored the major determinants of evacuation. So things that people considered when deciding whether they wanted to evacuate or not. So the biggest one is obviously the patient safety. If a hospital is not functioning, it is incredibly unsafe for the patients, and thus evacuation might be absolutely necessary. However, morbidity and mortality of evacuations are not really well recorded. There can be things that affect a patient's care even during evacuation, whether it's delay of treatment or lack of resources. If a patient is on a ventilator and they have to be off of a ventilator for so much time because they're being transported, that could be life-changing for a single patient. So keeping that in mind, that evacuations by themselves are not completely harmless. Then there's the continuity of operations. So this is often the most considered factor for most hospital executives, whether a hospital can continue functioning. Realistically, it is more beneficial to continue functioning than to try to evacuate, because even if we are able to maintain basic functions, then it can be more helpful for the community as in the greater good than actually evacuating an entire hospital and having a non-functioning hospital for the community. But a lot of times that might not be a reality for patients if you don't, or for hospitals, in the sense that you might not have the resources to even continue basic operations. A huge determinant of that is electricity. So if you don't have enough fuel to operate an entire hospital, or even like parts of the hospital, then sometimes that's just the decision is made for you. A lot of people have considered prior experiences. So evacuation, during Hurricane Sandy, a year before that, there were several evacuations prior to Hurricane Irene that showed false confidence in shelter-in-place decisions. So what happened with Hurricane Irene is that there were several hospitals that actually evacuated in preparation for Hurricane Irene, anticipating that that would be a huge disaster. It ended up not being as detrimental as originally predicted, and a lot of hospitals felt like they evacuated prematurely and unnecessarily. So then a year later, when Hurricane Sandy hit, they felt confident that shelter in place would be a better decision than early evacuation. That ended up becoming not the case, and Hurricane Sandy actually became so devastating that a lot of places had to do post-event evacuation as a result of the resources that were destroyed because of Hurricane Sandy. And then finally, there is the cost. It should not be the main consideration, but it has to be considered in any situation. Like I mentioned in the last PowerPoint, cost and financing is very important in planning, making any decisions that are involved in disaster preparedness. A lot of hospitals that evacuated or closed down during Hurricane Katrina never really opened up again because they never bounced back from the cost. Obviously, you don't want to consider that over patient safety, but that is something that is on the forefront of a lot of people's minds. So, like I mentioned, in Hurricane Sandy, there was no real decision criteria. So after all of these hurricanes, the Agency of Healthcare Research and Quality, or the AHRQ, actually made a hospital evacuation decision guide. This was a huge monument because it really gave us a way to evaluate different aspects of pros and cons of hospital versus shelter-in-place decisions, or hospital evacuation versus shelter-in-place decisions. It also provided an algorithm, which I'm going to talk about right here. So, in the scope of impending disaster or event, you obviously want to do the pre-disaster self-assessment. This, I didn't actually put any slide showing what the pre-disaster self-assessment included, but it included basically being aware of what your hospital's actual faculties and capabilities are. So that means that if you are a smaller hospital that has nowhere to put a generator except for in the basement, and you know it's going to be the first thing to be flooded, you are probably going to want to evacuate sooner than a larger hospital that has put in more resources to protect themselves and continue operations even despite a hospital. Being aware of those things are really important in the pre-disaster self-assessment. The decision guide actually has several different self-assessments that have different questions that you can actually answer and determine based on that. So I'll talk a little bit about that later, but that is something that you can kind of look up and assess or go through yourself for your hospital. So you might, based on that decision, you might want to decide whether you want to order a pre-event evacuation or not. So let's say you decide that your hospital is not prepared to maintain or function under a disaster situation like a hurricane, then you might start evacuation. So you want to determine consequences of patient evacuation, which the guide also kind of aligns for you. And then you carry out the evacuation if you determine that the consequences or the sequence is appropriate. Let's say that you do not decide that you want to start the evacuation at this moment. Then you might wait and reassess and kind of start the entire process over again before the actual hurricane hits. Then, let's say for the time being you decide that you want to shelter in place and you wait for the hurricane to actually hit. Then you want to assess the status. So then there's an updated self-assessment based on the status of the hurricane and your resources after the hurricane actually hits, and then you can kind of make a decision based on what the outcome of the hurricane actually was. So if the danger has passed and there's no threat any longer, then you might decide there's no evacuation and there's no decision made after that. that is that you successfully sheltered in place and that was the end of that discussion. Then there might be an immediate threat to patient and staff safety. So then you might order an immediate evacuation because of that immediate threat. And then there might be a potential or evolving threat to patient, staff, or safety. So an example of that would be like in Hurricane Katrina. The hurricane hit itself and everyone felt like they were fairly well prepared for the hurricane itself, but then once the levee broke, that would be considered like a potential or evolving threat for patient or staff safety. So if there is a potential or evolving threat, then you might order a post-event evacuation. You can wait and reassess that and kind of go back to the beginning and assess status, or you can start evacuation, and the same thing as the pre-event evacuation, you determine the sequence of patient evacuation and then you actually carry out the evacuation. So this is a really good algorithm to kind of walk you through it. The algorithm by itself is not super helpful, but in combination with the self-assessments that the hospital evacuation decision guide provides, it can be really helpful in making that decision when determining whether to evacuate or stay shelter in place. Then, like I mentioned, it also offers self-assessments to determine a hospital's personal capabilities and vulnerabilities. So this is an example of one of those self-assessments. So this is evacuation time self-assessment worksheet. So it kind of lists the evacuation related resources and the implications of each resource. So if you're thinking about patient transport needs, it talks about things like what percentage of the patients can self-evacuate, and if the percentage is like fairly high, that means that would be fairly good thought or factor to decide to evacuate. Then what percentage of patients are ambulatory? They can be evacuated in a bus. Maybe they might have like a broken hand or something like that. They might not be able to drive themselves, but they can be evacuated in a bus. What percentage can sit up but can't walk? So they might need wheelchair vans. What percentage require medical attention at the BLS level during transportation? And then what percentage require life support equipment and they cannot be evacuated in an ALS ambulance or med-evac helicopter, or they only can be evacuated in an ALS ambulance or med-evac helicopter. The higher the percentage, the more vulnerable if ALS ambulances are scarce. Then things that you want to also consider: how long would it take to get all the patients out of the hospital and on the road to another location? Assuming that the hospital is full, the roads are not damaged or blocked, or appropriate vehicles and staff are available. And then does the hospital plan specify an off-site assembly point where patients could be moved without vehicles and from which transportation loading vehicles would be faster? If there's no off-site assembly point specified, that means that they are more vulnerable to not being successful in their evacuation. How long would this two-stage evacuation take? And how quickly could all the patients be moved out of the building in case of a fire or any other emergency? Then you want to also assess the closest appropriate care sites. So how close is the nearest site that can provide all of these different things? This is not a complete list, but big considerations are NICU patients, PICU patients, CICU patients, and other ICU patients. In addition to that, you also want to consider psych patients and other vulnerable populations. So are they less than a mile away? Are they 1 to 5, 6 to 10, 11 to 20, or even maybe like 21 to 50 or 50 or more? So just understanding how far away that is would become a huge deal too. I haven't really listed it, but another aspect of the self-assessment is talking about whether roads are damaged and what are the realistic possibilities of actually evacuating a patient. And these are all things that the self-assessment worksheet helps to kind of determine, make sure you don't really overlook any aspect of the evacuation. So that was my presentation on hospitals. I hope that you got a fairly good idea about what kind of things to consider when a hurricane hits, from simple things and short-term effects like injuries and drownings to long-term effects such as the Katrina Cough and mental health effects. It also kind of outlined a little bit of how to decide whether to evacuate a hospital or to shelter in place, which I think is really important decision to be made during a hurricane setting. So hopefully you guys found this helpful, and I hope you enjoyed it. Thank you very much.